Hello and welcome everyone to tonight's webinar, the third in the series on cardiac care in the ACT. This webinar covers GP management of heart failure. I'm Dr. Leonie Harcourt, a GP education advisor at Capital Health Network. Also with me tonight is Kunal Mohiti, the events lead at Capital Health Network, and of course our expert speaker, cardiologist Dr. Sharon Wilson. The next cardiac webinar will be on the 20th of August and Dr. Mohammed Paymard will cover arrhythmias. So first, we would like to acknowledge the Ngunnawal people, the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. We also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending today's event. So housekeeping, all participants have been muted, and please type your questions into the Q&A box on your Zoom's window, not the chat box. Sharon is happy to answer questions throughout the presentation and also at the finish of the presentation. And this webinar is worth 1.5 hours of educational activities, which you're able to self-report to your CPD home. So you might notice that Sharon is appearing as a beautiful hound on your Zoom window. She's having problems with her computer and the camera on her computer. So just rest assured, she's a very wise her dog or hound, and her avatar does speak. So a little bit about Sharon. So Sharon grew up in Canberra, so she's a ACT local, and she left for university in Sydney. She holds an honours degree in genetics and then started postgraduate medicine at the University of Sydney in 2006. She undertook her cardiology training via the Eastern Network in Sydney before leaving for advanced imaging fellowship at Addenbrooke's Hospital in Cambridge. Sharon then stayed in Cambridge for over 5 years and gained experience in all aspects of cardiology, and especially areas that are not common in Australia. She is a specialist in maternity cardiology, inherited cardiac conditions, and multimodality imaging. And she has experience managing complicated patients and their families. She's also very interested in physician training, which she continues to do via supervision of basic and advanced trainees, both here in Australia and in the UK. And in her spare time, she tries to convince her dog, a Cairn Terrier, to behave. So thank you very much, and over to you, Sharon.
Thank you for having me, and apologies on being a dog, but it's more kind of the case of that we are what we are. So basically, I'm going to do a bit of a talk about heart failure. So at any point, if you do have any questions, please just interrupt. I'm more than happy to stop talking for a period of time. So I'm going to go through some of the ways that we're looking at heart failure now. So as you're all well and truly aware, we've got the patients that are at risk for heart failure who have got no current symptoms or signs at present, but they actually have some risk factors that we need to work on, which is the common ones, which is the cardiovascular risks of hypertension, obesity. Exposure to cardiotoxics is something that people don't often think about. Some of our genetic cardiomyopathies is something that I'm going to mention, as well as a family history of cardiomyopathy. We also then go on to, unfortunately, develop people in pre-heart failure, which is people who don't have signs, but they're actually starting to have some problems. So they either have structural heart disease. When you have a look at the echo in a bit more detail, we're starting to see increasing filling pressures, or they start to have biomarker changes, whether or not that's the troponin starts to leak or they start to have an increase in BNP. Then we start to go on to the ones that we see quite frequently, which are people who've got stage C heart failure, which is they're starting to become symptomatic. They've got signs that we get a little bit concerned about. And we usually have people who are either new onset or de novo heart failure, which comes out of the blue. But when you go back in time, you usually find some pointers on how this ended up there. You either get resolution of symptoms after you've done your initial treatment. You then can get persistent heart failure, which is unfortunately the way the majority of them go, or you start to get worsening heart failure. We then go on and have a look at basically when we get to the end stage of disease, we end up with the patients that have got the end of the road, which is basically they've got advanced heart failure and they have marked symptom decline. And they start to do the bouncing in and bouncing out of the hospital system if they have lots of symptoms that are interfering with their daily life, lots of presentations to both hospitals and to GP clinics in order to try and optimize despite what you've done with your goal-directed medical therapy. Let me just try and work out how I made Leonie big and myself small, because I was just trying to get rid of my little dog. So we have a look at basically some of the classes. So we talk about people with the NYH class. Basically, class 1 is people who don't really have any symptoms, right through to the people who are class for the class 4 patients, we have to think about what we're trying to achieve. Most of the time, what we're trying to achieve in our in-stage patients is to ensure that they have an appropriate and a good death, and that we have to start thinking about involvement of hospice care early and involvement of the palliative care team. The palliative care team, as my palliative care colleagues would like to enforce, is not just for cancer, it's also quite useful in the in-stage heart failure world, because they can help you with IV diuretics and things along those lines to try and keep the patients out of the hospital rather than having them to go backwards and forwards and in and out on the merry-go-round, which can be quite frustrating for both the people looking after them as well as the patient and their families. They can do IV diuretics in the community. They have a lot of resourcing to do home oxygen, and home oxygen becomes quite important when we have these patients who feel like they can't breathe. Just to give you a bit of an example of when we have a look to see what we're identifying is when we have an echo, you can see in the top left corner, you've got a person who's got a normal ejection fraction. These are short axis pictures showing that the mitral valve and the LV is actually working properly. So this person's got an EF that's over 55, which is what we would class as normal, as compared to the bottom picture, which is somebody who has an ejection fraction that is significantly in problems. So this person has an ejection fraction somewhere between 15 and 20%. So they've got severe impairment of LV function. Most of us are very good at working out normal versus abnormal, but we've got a range of patients that fall within the middle. So they've either got a mildly impaired ejection fraction between sort of 40 and 45, or they also have a more significantly impaired ejection fraction between 30 and 35. And these are the people that are the growing workforce at the moment within the world of cardiology, because we are seeing a lot of people who are walking around with a little bit of failure, but not a lot of failure. But it's a very slippery slope to go from 45 down to the 25%ers pretty quickly. We know that with the heart failure incidence in the community, we would expect that quite a lot of patients are actually going to be living, 1 in 4 is expecting to live with heart failure at some point in their life, which is quite a significantly large number when you think of it on a population basis. The other thing that's quite interesting to be aware of is quite a lot of these patients are elderly, quite a lot of these patients have got coexisting frailty, and that's why we sort of have to think about them in a bit more detail, because quite a lot of the symptoms they're having from being frail are actually symptoms relating to failure. When we have a look at some of the Australian data, one of the articles that came out about 3 years ago was having a look at the long-term life expectancy following a patient being actually admitted into the hospital. So there's quite a lot of a decline. So if you're a younger person, so if you're under 55 is their sort of what they would call as younger, you actually sort of once you had an initial decline of people who developed quite progressive, quite fast things such as myocarditis or the genetic cardiomyopathies, they do relatively well out to a 10-year point. But if you have an older person who's in the over 85s, we're nearly as fast as a hip replacement to basically ensure that once you start the first hospital presentation, if you're over 85, your survival out to 2 years is only a quarter of them are still alive. We know that there's a lot of population data of a lot of old people die when they go in and out of hospitals, but the slope of the ones that are the patients that we don't think are as much at risk is the people who are in the 65 to 74-year-old range. Their survival curve is also not particularly good. So we would say that after you've had your first hospital presentation with failure, only 50% of them are alive at 6 years, which is a lot sort of more intense than you would think about for somebody who is actually a relatively young person who's only 65. So there's 2 major types of heart failure, and we talk about them in abbreviations quite a lot because we're cardiologists and we don't like wasting words. So we have heart failure with reduced ejection fraction, which is basically anyone who has an impaired LV function. And then we have heart failure with preserved ejection fraction. So your ejection fraction on your echo is actually within normal levels. So we would say HFrEF, which is the reduced ejection fraction, is when your ejection fraction is under 40%. But then people usually come back with, but normal's 55, so why do you pick 40? And it's primarily because there's a lot of discussion across the world of where is normal. Is normal 55? Is normal 50? And so they had to make a bit of a differentiation between reduced ejection fraction and preserved ejection fraction, primarily because what they were looking to do was to be able to identify these populations in various clinical trials. The main difference between the heart failure with preserved ejection fraction from the more common reduced ejection fraction heart failure is this is more diastolic impairment. So this is usually a middle-aged lady who's got a slightly increased wall thickness or a small LV cavity. The heart still moves, but if you look at it, there's two components to movement, which one is rotational movement, which is radial movement, and the other one is basically shortening. It can shorten appropriately, but it can't actually turn particularly well because it's stiffer than it should be. And so we treat them slightly differently. So when we go back and we have a look at some of our non-traditional risk factors, we've got our normal cardiovascular risk factors for ischemia, but we also have a look at obesity, and obesity is becoming a significant talking point within the cardiology community. So looking at the ischemic risk factors, I'm sure you know those backwards, but some of the other non-ischemic ones, which are the ones that are the ones the sort of the little footnotes that you think about, but you sort of don't really actively think about on a daily basis unless you see these patients consistently, is basically the chemotherapy exposures. We are seeing quite a lot of these appear because people have either survived their cancer that they had when they were younger and they're now running into problems because we're at the appropriate time course. We're seeing quite a lot of autoimmune and rheumatological problems and patients going on to have failure. Some of our endocrine, primarily the endocrine ones, are the people who have obesity. Occasionally we do see it quite floridly with people who've had problems with their thyroid and have been running tachycardic for an extended period of time, so they effectively have a tachycardia-induced cardiomyopathic process. Some of the familial ones, and there are quite a lot of families wandering around in Canberra that actually have an underlying dilated cardiomyopathy. The heart rhythm-related ones, whether that's tachycardia, whether or not that's PVCs, you need to remember that when you do a Holter, you're allowed up to 5% of your day is PVCs, but if it's longer than that, and there's some that I've seen, I saw one today that was quite good at 28% of the day was PVCs, or the other ones that we are very good at forgetting about, the person who's effectively pacing dependent. We haven't gone back and had a look at their LV function for a good period of time. We are IV pacing them so that the heart is slightly skew with, so it's not as efficient as it should be. Then you've got some other groups of people with the inflammatory diseases, which are the ones that are kind of interesting. Myocarditis, which made its dash during COVID because it was quite popular then, but it is quite popular every time there's viral illnesses going around town. Peripartum cardiomyopathy, Takasubos, and basically the ones that we all forget about, or I know I forget about most of the time, is talking to people about what substances they're on. Primarily the one that we talk about a lot is cocaine and amphetamines. So having a wee look at a few things when you actually have a look at the patient is the standard things that you do for all of the cardiac patients. Have a look at them, measure their vital signs appropriately, and then basically go on and have a look to see what you can see on their base investigations. For us, the base thing, like a chest x-ray, is having a look with an ECG. So it's more what rhythm is the patient in, and we can get quite a lot of useful information. Unfortunately, a lot of GP surgeries now don't have ECGs, and you send them up to the pathology and there's a bit of a delay getting things back, but it's more kind of the case of it's a very useful test. The other tests that are quite handy is basically having a look at the lipid profile, not just the straight total cholesterol, but having a look at the subdivision. But that's sort of with my other hat of looking at lipids a lot. But if you think that there might be something there, going down some other diagnostic pathways, so if you think this person could potentially have sarcoid and ACE level is useful, but you're not going to do that in everyone. There has to be some clinical features that make you think about it. We do a lot of, if this person in failure, we do a lot of iron stores because there's a lot of evidence coming through that having somebody who's iron replete actually does better. So you'll see us start doing a lot of iron stores and wonder why are we doing that, and that's one of the reasons. So when we have a wee look on what we've done the examination, we've done an ECG, and we've kind of gone, oh, hang on, maybe does this person have failure or not? One of the sort of little interesting bits about Medicare is you at that point can do a BMP, and you can get a Medicare rebate on a BMP, but once you've done an echo on a BMP, you can't do a BMP without the patient being charged, because the BMP is being used as a safety check to say, does this person need an echo or not? So BMP, if it's over 500, we can say that it's cardiac. If it's in the grey zone, it could be cardiac, it could be respiratory. And if it's completely under sort of normal, under 50, then we would say that it's unlikely to be cardiac in origin, but we would say we'll take it if it's over 500, but there is a bit of a grey zone, and we need to keep remembering about the grey zone.
Sharon, could I interrupt you for a
Sure.
question there? So would you recommend that GPs do the BNP or leave it up to the cardiologist? So,
Oh,
for
I love it
example,
GPs are great when they do it. So
Okay.
it's more because you can do it before the echo because
Yeah.
our natural reflexes, I don't know if this person's got failure or not. It's pretty easy for me to get an echo. I've got hands, so I can go and do it myself. But it's more kind of the case of I know for GPs getting direct access echo, it can be a bit of a challenge. The BMP, like it's used to be a test that they had to send out of Canberra, but they can do it in Canberra now. So you'll get a turnaround in about 3 hours.
So if someone came in with swollen ankles or they had kind of crackles in their chest or something like that, it would be reasonable for a
Yeah,
GP
it's
to do
reasonable.
the
It's totally fine.
Yeah.
Yeah. And it's more kind of the case of if you look at some other jurisdictions, so maybe not the ACT, but if you have a look at like how they're doing in Europe, that's how it happens. You can't get a patient into heart failure. You can't get a patient in for direct hospital review in outpatient clinic without a BNP.
Okay.
So they use it as a gatekeeper. It's quite a good test, and it's a Medicare rebatable test, provided they haven't had an echo. If they have had an echo, then it's not rebatable. And Medicare are quite good at checking have I provided a service rebate on an echo. So even if they've had an echo, like in the distant past, they'll be able to find it. But it's more kind of the case of I'm very happy if GPs do BMPs because it's quite handy because sometimes it's like, is it lung? Is it heart? Is it, I don't really know. And it's quite useful for us.
Great.
Um,
Thanks.
so
Sorry.
no, it's fine. If people have done, so you've gone, yeah, reckon it's failure, let's go get an echo and have a squeeze. So the echo is quite useful for us because it helps us try and work out why, and it helps us give it a measure of, are we going to do treatment and what we're going to do. In our initial reclassification, we kind of go, this person's got a heart failure with reduced ejection fraction. We will go back and have a look to see, have we improved, which becomes heart failure with improved ejection fraction, or are we still sucky? So you're still heart failure with reduced ejection fraction. You can get heart failure with basically the middle zone, which is the people from 41 up to 49, which is kind of is this actually improving? Is this not? This is the grey zone people. They can either get worse, stay the same, or get better. You can have the people who've got preserved ejection fraction and they can either get worse, get slightly worse, or they can actually stay about the same. So we do use echo and a serial motion to see, is there any benefit here? Other tests that we use quite often is basically chest x-rays to kind of see, is there anything else we can blame this on? Are they breathless because they have a large underlying lung pathology? Are they hyperinflated? Do they have large pleural effusions? That's quite handy. Sometimes you can't hear or you can't find it on examination because the patient has got a challenging body habitus is a nice way of saying it. We can, if we've got an echo probe, you can have a look to see if you've got sort of a sliding lung, because if you've got a large amount of fluid, you'll be able to see it. But echo is a class 1 recommendation to go on to basically get some useful information. When you decide to be a bit fancier about going through cardiac CT, CMR, or SPECT or PET, if you've got a person who comes under the heading of good luck, no one can see anything there, it doesn't have to be a large person. Sometimes it's about how big and wide your rib spaces are. If you can't see, you can't see. So doing an echo on basically a sort of polar bear in a snowstorm, you're not going to see anything. So that's when we go and have a look in different other directions. The only one that's rebated in Australia is CMR is rebated under very, very tight indications. Cardiac CT has got quite widespread access, but it gives us an idea about plumbing, but it doesn't give us an idea about function. SPECT or gated heart pulse scans are sort of useful, but not the world's greatest test because there's a large amount of radiation in it. PET's really good, but PET is not indicated and doesn't have a rebatable indication for Australia. And the other tests that we do occasionally use, because we can't see anything is going on for MIBI. MIBIs are relatively all right, but there's quite a lot of radiation in MIBI, which is something you have to think about. The class 2 recommendations, if you've got a person who has a cardiomyopathic process, once you've diagnosed it, you can get quite a lot of useful information from a cardiac MRI, but unfortunately that's not rebated in Australia outside of a hospital setting. So there's class 2 indication of they've got somebody with failure, do I need to go and see if the coronary is okay? It's only a class 2 indication. Class B is basically if you think this person actually needs to if you've got something that you think you can fix, going on to do non-invasive testing beforehand rather than just fixing it is a class B. And there's no benefit in the guidelines across the world of basically, unless there's been clinical change in the patient, you've got a treatment or an intervention you can do that can make a difference, or you've got a patient that you're trying to work out of, are you a candidate for something else? So, for example, if you've got very dilated hearts, are they a candidate for a mitral clip? Are they a candidate for a triclip? doing routine investigations of the LV function, unless you've changed something, is not an indicator test. So the person who has the 2 echoes every year for the rest of time, and you haven't actually changed anything, and you don't think that you're going to get interval change, is not an indicated test. We know that we have a lot of scoring systems, and everybody loves a scoring system of the, am I winning? Am I doing the same thing? So we've got ones for acute heart failure. We have ones for chronic heart failure. And it goes under one of the rules in my life of, if you have lots and lots of scoring system, it means that we don't know what we're doing. So there's no real point using a scoring system. So the only one that actually does seem to have any evidence that follows it is basically having a look at one of the Ohio scoring systems, because it actually is not validated yet, but it's probably going to be the one that it's the Kansas City. So we've got the Kansas City Cardiomyopathy Questionnaire, we have the Kansas City Quality of Life Questionnaire, and they're developing the Kansas City Heart Failure Questionnaire, and that's probably going to be the one that's actually validated, because it's holding up and it's relatively easy to use. But it's a case of, at the moment, I wouldn't be bothering with the scoring system, because they just have been used in clinical trial, but they haven't actually been found to be useful in clinical practice. But going back to the trajectory of what happens to these people, if we sort of leave them in peace, it doesn't end well, and the time course is actually relatively rapid. We tell the patients that if we don't treat their heart failure, they've probably got a life expectancy of about 2 to 3 years, but more at the 2 end, depending on how old they are. But we do know that the other thing that does cause us some problems is they do start to have little bits of periods when they're good, then they get bad, then they get good, then they get bad, then they get good, then they sort of start to, you never really get back to your baseline, and you start heading towards a refractory heart failure, which is unfortunate. At that point, if you do start to see the patients come in and out and in and out, quite a lot of it is related to compliance, because patients get tired of taking medications, they get tired of being good, something changes or something happens, or they change environment, or they miss doses. And sometimes we've got some people who are very, very finely balanced, so if they miss a dose of the medications, they can end up in problems. What we try to look to see what we can do is, we've got very good medical therapy now. So if you've got even a patient with heart failure with reduced ejection fraction, with the medical therapy we have now, we've got a 25% chance of getting them back up into the normal. We've got a 25% chance of putting them into the grey zone, but 50% of them will still stay in the reduced ejection fraction, but we can improve their symptom burden. We've got a relatively good chance, if they're in the grey zone, getting them back to normal. A third of them will stay still in the grey zone, but a third of them will actually get a bit worse. But it's more about keeping an eye of, how can we get you back to normal as much as possible. So primarily we go looking to medical therapy. We have a look at different modalities and what we can do. We've got different things that we've been doing a lot of thinking about. A lot of attention is being put on basically having a look at the cardiometabolic stress, or basically looking at the changes that we have with some of our larger patients. And that's where we use quite a lot of the GLP-1s, the SGLT2 inhibitors, which if you've seen any of my patients, I'm a bandit for handing out. And we've got some evidence for basically the mineral corticoids, which is one of the things that we do add in quite often. The mineral corticoids are relatively old school. The endocrinologists have got a bit on board with the mineral corticoids recently. They don't use spironolactone like the cardiologists, or they seem to be using finasteride, and they seem to be using quite a lot of it at the moment, because it's more that every person who comes in, you go, who gave you that? And it's usually the endocrinologists. But it's more kind of the case that there are some benefits for type 2 diabetes with it, because it does seem to have a reducing inflammatory effect. So we do have a lot of crossover with the endocrinologists, which is quite interesting at present. And we're all basically coming from the same group of, if a larger person can't breathe properly, putting a lot of cardiac stress, if we reduce the risk factors, we are going to see improvement. But the main thing that we look at now is, we've got 4 pillars of heart failure. So we have the beta blockers, which we love dearly. We have the ACE inhibitors. If somebody can't tolerate an ACE, we go to an ARB. I don't really start ACEs on many people. I usually go straight for an ARB. Or we go to one of the ARNIs, which is Entresto. It's usually very well tolerated. The problem is, you just sometimes have to sneak a tiny dose in, so they may not be able to even tolerate 24, 26 of Entresto twice a day. You might just have to start with 24, 26 one time a day. The potassium balance is something that we need to keep an eye of that. We also need to keep an eye on that with the MRAs. So for us, that we primarily use spironolactone. when people are getting very refractory, we actually get to the point of using a potassium binder so that we can actually give them the MRA to get the benefit from the MRA. We also are using quite a lot of the SGLT2 inhibitors. Adapa and empagliflozin in my life are effectively interchangeable. The trick with adding them into the patients is I usually give people a 5 milligram or half a tablet, even though the pharmacist usually has a mental breakdown, for the first week to see that they tolerate it relatively well, to avoid hypos, to avoid people having, I've had a few people recently who've had allergic responses to it, who've developed, I'm a person who developed really good hives. But if they can tolerate 5 milligrams, you've sort of given them enough time for them to get used to the idea. The other trick is to make sure they eat it with food or take it with food, because if they don't take it with food, you can get some abdominal discomfort. And then if they tolerate that, then to up titrate to 10. But we have to warn people about hypos. Don't start it on the type 1 diabetics. It does work quite nicely with the type 2 diabetics, but you just have to have a look at their glycemic control. And I usually ask them to have a blood test about a week later for the type 2s, just to make sure that they're not hypoing and not being aware of it, because quite a lot of them have got poor hypo awareness. There will be a bump in the renal function, but the renal doctors, because they also use quite a lot of it, are quite happy to sort of tolerate that bump. It does go back towards baseline, but we don't really look at people's creatinine for about 4 weeks, because we know it's going to go up, and it usually scares people when we go and find something that's abnormal. Some of the other additional therapies that you can actually use is if you can't get somebody to target, then you can use avabradine. Avabradine is really quite a good drug. It works on the IF channel, which stands for the funny channel. And what it does is basically tries to regulate the heart rate. It's very useful if you've got a person who's got heart failure who actually has no blood pressure, because it doesn't have any BP effect. Usually we start people at 5 and then up titrate to 7.5. If you have a larger person, it also has a body of distribution. So if you have a person who's more than 120 kilos, you can go up to 10 milligrams BD, because it sort of disappears if they're only on the smaller dose. We have got some evidence for using baricitinib. We use it mostly in Australia in a situation of pulmonary hypertension, but it actually has quite a lot of data that's starting to develop, and they're currently trying to get it through the TGA to use it for heart failure, to try and see if they can offload the right side to improve things. Digoxin, sometimes you go old school, because digoxin is basically not a particularly good inotrope, but sometimes it's quite handy, and it's quite useful if people are unable to tolerate some of the other therapies, because it can actually be used to sort of give them a little bit more preload. Omega-3 fatty acids are also relatively quite useful. We are seeing some benefit if we have sort of front-loaded people with the omega-3s. It is quite good for the lipids, but it seems to be there's another effect which they think is related to how mitochondrial action works. And then potassium binders, of if you've got somebody you're trying to get other drugs down, and your limiting factor is the potassium keeps sitting in the high 5s, heading towards the 6s, that's when we start looking at basically some of the potassium binders. But in all fairness, most patients don't really like them because they don't really taste very nice. Other things you can do is, depending on what you've got, if you've got a person who's hypertensive, fix it. If you've got a diabetic, try and sort it out. If you think that there's underlying coronary pathology, that's when you would go and think about either doing a surgery or PCI. If you've got a person who's got a heart failure related to an underlying cancer therapy, you need to have a bit of a discussion with the oncologist about what's going on, or the valvular heart disease, because we do have a lot of access to some of our interventional procedures that you can have a structural fix, which can improve your failure a lot. If you've got AF patients, because we know that when when everything dilates, you start to go out of rhythm, making sure they're anticoagulated appropriately, putting patients on appropriate iron replacement. The absorption of oral iron is not terribly good, so that's when we start sort of ask nicely if somebody can do IV iron replacement for us. And the evidence on that is currently 2A, but it's looking likely to be upgraded to 1 shortly. Having a look at people who've got AF and not particularly great rhythm, not particularly great ejection fractions. That's by having a look to see what can we do with device therapy, and do we need to think about ablations. Ablations comes back again because the EP doctors are getting very good at it. Even the patients aren't particularly brilliantly well. They're getting quite good at trying to put the rhythm back into something that is more sensible. Sleep apnea is something that we all forget about, because we do have a lot of crossover with the sleep doctors with the phenotype of patient that we see. But sometimes we can actually improve the pressures that are going through the people's heart, especially the people with diastolic impairment, by looking at optimizing their CPAP. And then the cancer people, getting them on the right drugs.
So Sharon, with the medications, especially the first slide with the beta
Mhm.
blockers, the ACEs and the
Yep.
spironolactone, are
Yep.
we titrating the doses in general practice according to their blood pressure, or are they apart from the beta blocker and the ACE, like with the spironolactone, are you saying 25 or 50, or how
Oh,
do we determine the
how you
doses?
determine it? So let's start with Spiro because it's the easy one. So cardiology is either 12.5 or 25. When you start getting into the higher numbers, you're talking to the gut doctors. So the gastroenterologists usually start at 75 and end up at 150. So we usually tank out at about 25. You can split dose them if the person becomes a bit hypotensive. It's usually it can be quite a good lunchtime medication because the diuresis they get if they are a little bit unloaded is you get a nicer sort of needing to go to the bathroom a little bit more in the afternoon, but not the dramatic frismite of the bathrooms are located 5 meters that way, 2 meters that way, and I can tell you where they are between here and the shopping centre.
Yeah.
I do have a man who can tell me exactly where all the bathrooms are in Belconnen Mall, which is a little bit creepy, but it's more kind of it's titrating. I usually stop at 25. The beta blockers, you guys can do the titration of the beta blockers. You're usually going to be limited with blood pressure rather than heart rate. The ACE inhibitor, when we have a look at, so what happens with the ACEs, the ARBs or the Entresto is more, I titrate that on BP, but if it's new de novo patient, I let everything sort of settle and then I start to push things. So I give them a bit of time to get used to the idea of, you've got heart failure now, we need to get all these pills into you. You've got 4 pills. The SGLT2 is not going to go up. It's basically going to go 1 week at 5, then to 10, then stop. The Spiro, you get to 25, then stop. And then it's more, you're then pushing your beta blockers and your Entresto. If you can't push, I push Entresto before I push the beta blockers usually, unless they have an underlying rhythm problem, and then I usually push the beta blockers. You can play with which beta blocker is your favorite beta blocker and then sort of move them around. I like the 24-hour ones, whether that's nebivolol or bisoprolol, primarily because people remember to take them. Carvedilol is very useful in the oncology setting because all the evidence is relating to carvedilol. But getting patients to take medications twice a day, sometimes we know they're going to get the shits because they have to take so many medications that we try to sort of make it as easy as we can for them. There was moves at one point to make a combined medication with Spiro as well as the Entresto in it together. They're 2 competing drug companies, so I don't think that's ever going to happen. Eventually, they probably will have combination therapy with spironolactone and the beta blockers, but that's the dream of ours, to sort of have less pills for the patients to take rather than having to take a handful. But this is something that we would like the GPs to sort of look at, because when we look at some of the data, which I'll come to, you can kind of see that there's a lot of people that when they look at them, Dr. Sidoni, who's in Concord, has got lovely data to look at. The patient was put on this in the hospital. The patient was still on the same dose 6 months later. The patient was still on the same dose a year later. The patient was still on the same dose 18 months later. And it's had some effect, but you could have got a fair amount of effect if the doses were up titrated. This is ultimately where it would be ideal if there was a heart failure nurse or a heart failure functional clinic in the public hospital for them to basically help you with up titration. But unfortunately, we live in Canberra. But there are a lot of people around who can help up titrate. Some of the cardiologists have got heart failure nurses in their rooms who can kind of help you if you need some advice. But most of us are relatively, hopefully, nice enough that if you go, should I increase this? We go back, yep, have a crack at it. Rather than sort of going, why are you asking me that question? It's more kind of the case of this is something that if their blood pressure is consistently sitting in the 120s, then it would be more Entresto, thanks. And I usually don't start to drop the doses until their blood pressure is consistently sitting in like the low 90s.
Right.
Because most of the people, if your injection fraction is sitting in the sort of 30s, you'll be lucky if you crack 100 for a systolic. So it's about being not scared to drop their blood pressure, because they're not going to have much blood pressure, and you know that the beneficial effect from having treatment is actually going to outweigh the hypotension you think you're going to see. So that's when you start with the 24, 26, 1 at night, and then the tiniest dose ever of beta blocker once you've got them clinically dry.
Right. Thanks.
So this is, see, next bit is titrating dosage. So it's more kind of the case of it's going back and reassessing to go, is the patient on the right drugs? Are they actually taking the drugs? The patients know why they're taking the drugs. And the other bit that we're all not great at in cardiology is basically trying to talk to the patients about the goals of their care. To go, you're at the beginning of this journey. What do you actually want us to do? If the wheels fall off, what would you like to happen? And sort of starting that conversation early so that it's not a surprise when they turn up and they're in florid failure. And then you go, you're going to be intubated. Do you want to be intubated? And then they look at you like, what? So starting to have those discussions early. Some of the other groups that we don't see that often in Australia, if you've got a person who is an African American, or a person who's from Northern Africa, you also need to have a bit of a wee think about nitrates because they work very well in that particular population. The use of the ICDs or CRTs are quite good, so you can get quite a good response if they've got a wide QRS on their ECG and they've got symptoms. And there's some other therapies that we would start to have a bit of a think about. Once we've got patients who are refractory, you either sort of are heading in a different direction, or we've now got symptoms improved. We still go back and recycle to have a look of, are you on the right drugs? Go back and have a look again, so that every time we see them, it's like, are your drugs right? Are you taking your drugs? Is there anything we can do to make this easier for you? Are you have any side effects from our therapy? Once they get into refractory, you're then sort of stuck with, if they're young, and if you do have something that you don't think you're ever going to be reversing, it's when you start to think about referring on for transplant. We, in Australia, the oldest person who's had a heart was 68. So they do transplant relatively old, not middle-aged people, rather than what we think that they transplant, which is basically people in their 20s and their 30s. We don't have destination VADs in Australia yet, but that may happen in the next couple of years. So a VAD is basically an artificial heart, which is a left-sided system. You can get basically complete artificial hearts for right device and a left device, but they're usually in people that we're bridging towards transplant. Palliative care, I think, is very important to get them involved. And then sometimes when you've run out of options, you start thinking about enrolling people into clinical trials. And there's a few drugs that are kicking around that might potentially turn into something. And there's always a clinical trial that they can be enrolled in potentially. But when we go back to thinking about it, it just goes back to the same four pillars, which is NMRA, the beta blockers, the ARNIs, and the SGLT2s. And we start to think about, is there something else I need to adjust? Is there something else I need to change? So, for example, if they roll in and they're congested, you use the thiazides and you use the loop diuretics to try and get them back to being dry. Then you start to, when it all falls apart, start thinking about some of the other drugs. Are they iron replete? Is there anything else I need to do structurally to make this better? Is there a rhythm thing that I need to ask the rhythm doctors to do some work for? Is there any other drugs I need to do to try and bring the heart rate down? The heart rate target we'd be looking for is anywhere between probably about 70 to 80. And I do use a fair amount of evaporating to try and see if I can get people down to below 70. It does seem to be more tolerated in the older people better, and those are the people that we're really throwing the kitchen sink at them to try and prevent them from having problems. So if you have a look at basically what does happen, we hope that when they've been in the hospital system, they've been started on the combination therapy of all four of the drugs. They go home, and then they're supposed to, hopefully in an ideal setting, be seen again shortly after they've been in the hospital, rather than everybody's favourite, please see your GP in 7 days with no information and try and ask them the questions. So in an ideal world, they would usually be followed up by a nurse practitioner or a phone call about 2 weeks later to sort of go, how are you going? Is everything behaving itself? Have you got any questions? Because we all know that when the patients have come in an acute deterioration, they have no memory of anything that we've told them. And then basically get their doses increased at that particular point. And that's where the first time you would look to basically take up the beta blockers and the ARNI in combination. And
Can
then
I
you would,
interrupt you, Sharon?
sure.
Sorry. Patients often come home on metoprolol BD, and sometimes they're a bit old. And that's a
I'll
hard
just swap
dose for
it.
them. Can you just put them on bisoprolol?
Oh, totally. So it's more kind of the case of there's no so metoprolol, everybody likes metoprolol. Well, it's cheap. So the hospital likes metoprolol. Everybody likes metoprolol because it's easy, but it's more kind of the case of, I think bisoprolol is easier to dose titrate than metoprolol, because metoprolol, if you change the interval with when you're taking metoprolol, so if you take it at 8 and then you take it at 6, you don't really have a good 24-hour delivery because you've got an overlap and then you miss a bit in the morning and then they become a bit tacky and then you think, oh, hang on, I need to increase the dose. Then you increase the dose, they don't take it at the right times, and then you're chasing your tail. So I very much like the 24-hour drugs. So I would swap it if they're on more than 5 pills, or more than 5 pills from new pills from the hospital, I just swap to bisoprolol to make it easier for them.
Right.
Because if
Thanks.
you've got a long-acting beta blocker, a BD dose of Entresto, an SGLT2, and Spiro, that's 5 new presents we gave you before. We also would have given you aspirin. We will have given you some form of statin, and the patients go home going, "Why am I now on 7 drugs? I was on nothing before. Why am I now on all of these?" So consequently, the smaller amount, the happier the people are. But ultimately, in an ideal situation, you would take your dose up about 2-3 weeks later after seeing them, and then 2-3 weeks, and then about another month afterwards, you would then see if you can increase your dosing up. The one sort of where we run into problems is if we've got people who have got sort of either low blood pressure or they're just not able to tolerate things. The majority of the time, it's basically if the potassium starts to drift. And that's when we would sort of think about potentially if they were on the 12, if they were on the 25 Spiro, dropping the dose back down or dropping out the ARB until you get the renal function to hold together, because sometimes you don't want to annoy the renal doctors all the time because they've been in the hospital, been belted with diuretics. We're trying to get people out of the habit of basically diuretics are very good short term, they're not very good long term. And we're talking sort of the thiazides and furosemide and its friends. The other thing to remember is, and we do see this not infrequently, is if you've got people who are on 120 milligrams BD of furosemide, they're probably developing furosemide resistance. So you can keep throwing furosemide at them, it's not going to work. So that's when we do have good access to bumetanide, and the dose equivalence for bumetanide is usually, it's like 1. So if the person's on 80 of furosemide, it works out to be about 1 milligram of bumetanide, but bumetanide actually does work very nicely. Acetazolamide is a bit more fiddly, and if I was in GP land, I wouldn't be touching that one. I'd be sending that off to specialists to play with, simply because it's a lot of monitoring and it's an arse, because patients don't tolerate it particularly well, and you have to keep a very close eye on the fact that you can really cause their kidneys harm. I don't usually start ezetimibe unless they're in the hospital, and that's a relatively rare patient. I've got a few people walking around on bumetanide because they just do better on it, but that's when they were previously on some hefty doses of furosemide.
Sharon, another question.
Yep.
Best beta blocker for asthma COPD overlaps?
I like nebivolol for that because nebivolol seems to work nicely. Bisoprolol can make people wheezy. Carvedilol seems to be okay tolerated. Most people seem to do all right on nebivolol. So if they say the words, I play the game of have you been admitted to the hospital? Have you ever been intubated? Have you ever been admitted to the hospital for your asthma? Have you ever been, and are you on more than 2 different puffers? And if the answer to that is yes, then I kind of go, let's try and see some other things. And then I usually primarily will go straight to ivabradine. If they've ever been tubed for their asthma or their reactive airways, I just usually chicken out and go, let's go for ivabradine because that doesn't cause any airway issues. If they've had multiple admissions, and there are multiple puffers, then it's nebivolol. If it's I had asthma as a child, I go, let's try it and see what happens, and then just use whichever beta blocker I felt like giving out that day, which is usually bisoprolol. But it's intubations I get a bit nervy about, but I think that's relatively fair.
Yep, thanks.
So the other ones to think about is the I need help. If you think this person needs tropes, if their class of function is getting worse, if they're starting to develop end organ dysfunction, the one that we all need to keep remembering about is liver function problems that go off that you can't really find an answer for. The answer is they've got right heart failure. If the ejection fraction is under 25 or under 35 and you're causing problems, if they have a device and they're getting multiple shocks, if the hospitalizations are basically more than 1 a year, if they've got increasing peripheral edema, you can say this is American because they can't spell because it's not no. If they've got a blood pressure that's sitting under 90, or basically they can't tolerate the goal-directed medical therapy, that's when you sort of have to sort of put your hand up and go, can somebody help? There's a couple of special groups that we need to keep a bit of a wee eye on. One of the ones that people don't know about is basically our cardio-oncology patients. We do see a lot of heart failure that's been developing after people have had a lot of cancer therapy. The main ones that we don't like are the anthracyclines, because the doses that they were giving out in the 70s through to the early 90s for childhood cancers were cardiotoxic. They survived their childhood, but they're now turning up with heart failure. The other ones, which is a big group of people, are the people who are on the hormonal breast cancer treatments. Some of the newer agents that we have, we've got some problems with some of the checkpoint inhibitors, which also cause heart failure, and also there's some of the VEGF inhibitors. To borrow Donald Ronsboss, which is gone super old school, it's more, this is very much cardio-oncology. We know something about it, but we know there's lots we don't know about it, but there's a lot of things we don't think we know anything about it. And if somebody tells you that they know everything about cardio-oncology, you know that they don't know much about it. But all of the drugs work in different places within the heart, but the failure ones are basically more the primarily think about it of the way of if they've seen the hematologists and it was about 15 years ago, you're thinking to yourself, if this person's got failure because the anthracycline dose was quite high. Some of the newer agents that they do use, some of the melanoma treatments, some of the other treatments for some of the, and this is where we're even getting to some of the rheumatological drugs, they're actually been found to cause isolated hypertension. The hematologists are also cracking out thalidomide and some of its RANs for some of the lymphomas and some of the leukemias, and they actually cause quite significant ventricular arrhythmias. But we also see some other things. Valvular heart disease is also quite common, and you can get heart failure from radiation. So you need to also have a bit of an idea and a think about it if the person's got left-sided breast cancer, because even with the best will in the world, the heart's still within the field. So when we go and have a think about our cardiology risk factors for oncology patients, there's no Australian guidelines because we haven't caught up to the rest of the world, so I use the English guidelines. They basically go, if a person's going to go have something that you think could be potentially cardiotoxic, you do a base echo to see where you're up to. There's the standard protocols with the Europeans and the Americans and the English is basically if you are on a cardiotoxic chemotherapy, primarily think of it like Herceptin, you're supposed to be having an echo every 3 months. The standard Australian protocol seems to be using gated heart pulse, but echo actually is more useful because echo can show quite a lot of different changes in how it moves rather than just what the EF is. The EF by itself is a system that we moved away from a good number of years ago, but the oncologists haven't caught up with it. But if you do see that there's an impairment, we've got lots of drugs that we can actually use to try and help their heart survive. We do, and we have to be relatively reasonable about the fact that we need the cardiotoxic for them to survive their cancer. So we're just there to support the oncologists as they can look after the patients. When we're looking for cardiotoxicity, we're seeing a decline in the ejection fraction. We're having a look to see how the radial, how the heart rotates, how that's going off. And we sort of have scoring systems. If we have changes, then we put different drugs in, and that's where we start handing out carvedilol. But if it otherwise looks okay, it's just continuing to watch it. After people have finished their cancer, we need to also remember that the effects go on. So we actually start to see people again at about a year after they finish the treatment, just to make sure everything's holding fire, because we do start to see some things, and we have got data to show that, going back to, we'll blame the hematologists, that there's patients that have had their initial treatment 20 to 30 years ago who are coming in with problems. One of the other groups of patients that causes a lot of consternation when they appear in with heart failure is basically our maternity patients. You need to remember, if you've got a congenital cardiac patient and they're now surviving into adulthood, then they turn up and they go, I want to become pregnant. Please send them to somebody who can talk to them about it before they decide to become pregnant, because then you'll save several chunks of my grey hair, which in the dog model would be my main forelock, of having to talk to people about the fact that their heart may potentially not be able to cope with the load of pregnancy. So we like to see them early, but any patient who's got underlying cardiac disease and is a young person going on to carry a pregnancy can be a bit of a challenge. We do see a group of patients who've got a thing that's always kind of hard to deal with, which is basically peripartum cardiomyopathy. So if somebody becomes acutely breathless during pregnancy, or just comes in and you go, there's something about you that doesn't look right, the answer on that in my life is to basically get an echo so that you can just make sure that they're not going into failure, because it is relatively common. The ones I can think of off the top of my head in the ACT, there's been at least 20 in the last 2-3 years of people who've turned up with massive amounts of failure. The best one was a person who thought she knew otherwise better because she was a cardiology nurse. She was carrying twins who turned up with an ejection fraction of 20% when she actually got round to getting it assessed when she collapsed. But it's more kind of the case of if you've got a person who's acutely breathless, you're a little bit worried about them, there's just something not right, and GPs have got a very good way of determining there's just something not right with this. Ultrasounds sometimes are quite helpful because it doesn't involve radiation, which is something very easy to sell to a pregnant patient. If you've got a person who's got known problems with heart failure or cardiomyopathy, you have to be really careful with some of their drugs. The main drugs that you have to think about is not as much of a problem as it used to be. Is atenolol actually causes quite a lot of issues. Atenolol actually has been shown to cause birth defects, so we usually get people off atenolol pretty quickly. Bisoprolol is quite safe. Metoprolol is quite safe, despite it being a Class C medication in Australia. It's used around the rest of the world. The ACE inhibitors you can't be on. You can't be on Entresto. You can't be on any of the ARBs because they can cause quite significant birth impairments, and they also increase your risk of miscarriage, so we do not have them on patients at any point. Statin therapy, we also don't have people on for the first trimester. We actually would reintroduce statin therapy if they've got a familial hypercholesterolemia at the end of trimester 2. And that's only in very special circumstances. Most of the time we just let it free range because you do need basically your cholesterol to make things, especially if you're making a baby. Avabradine is not indicated in pregnancy because there's been, I think, 18 cases around the world of patients who went through on avabradine, and I think it was something to the tune of 15 of them ended up with miscarriages. One got horrible birth impairments. So avabradine in pregnancy it's fine if they were, I didn't know I was pregnant, I was still taking it, but the sooner you hear the words, I think I'm pregnant, or the pregnancy test has gone positive, stop it. And you can cold turkey stop it. The SGLT2s and some of our newer agents aren't and don't have any data in pregnancy, so we don't let people go through. And some of the people who are on some of our pulmonary hypertension, we do not go through with our pregnancy when patients are on those drugs, because pulmonary hypertension in pregnancy is not a good idea. So if you've sent the person off for an echo and it's come back and they've gone, you've got a dilated cardiomyopathy, and you've gone, awesome. Now, what do I do with that? You kind of have to have a bit of a think about it of what's the cause of these, and these are some of the commoner ones. So it's more kind of the case of we do have a very big group of we have no idea, which comes under idiopathic. We uncover quite a few people who've had a high alcohol intake, which they haven't actually told you about until you specifically question them. The endocrine ones, which is the obesity, cardiomyopathic people, we do see some of the autoimmune ones. We do occasionally find, and it's not uncommon to find, a heart failure as a first presentation of one of the muscular dystrophies. The other group you need to think about is heart failure, something doesn't seem right and they can't tolerate statins. That's usually a clue that there might be an underlying muscular problem, because we do interestingly see quite a lot of statin intolerance in the muscular dystrophy people, which can be up to about 5 years before they start to develop the muscle problems, which is interesting. And there's a lot of people thinking about that around the world at the moment. Occasionally we see people who've got an infective cause, whether that's myocarditis, but they're usually myocarditis. It's not a I'm at home type thing. Myocarditis is you're in hospital barely alive. We used to see it not uncommonly in the HIV population, but with the newer drugs, we're actually not seeing as much of a problem. The other group of people who turn up with the unexpected dilated cardiomyopathies are the new presentation of a familial cardiomyopathy, and there is quite a large group of those that sort of decide to turn up for a surprise. But that's usually a diagnosis of an exclusion, and when you go back and take a 2-level family history, so go back to grandparents, go out to cousins, you will find people in the family who have an underlying issue that you didn't know about beforehand. But it's more, a new DCM sort of involves a little bit of thought, but it's not uncommon.
With people with a family history of cardiomyopathy, how much do you have to screen relatives?
So the way I would screen so there's different types of cardiomyopathy you would screen for. So if you bring it in the easy ones, so if you've got a hypertrophic cardiomyopathy, you screen above, so you go 1 generation above, 1 generation below, because that is, you've got a risk of sudden death. If you've got a dilated cardiomyopathy, I don't bother screening. I don't screen the parents, I screen the children. Because if you've got most of the time of the onset of that, they're in their sort of like 30s to 60s. So if you're an 80-year-old with dilated cardiomyopathy, it usually comes under the heading of, that's nice, we'll try to do some things for you, but there's not much that we can do to ultimately change your benefit. Some of our other ones, which I'm going to talk about now, like amyloidosis, that's when you have to screen the patient the level above and the level below, because amyloid is a sneaky diagnosis that kind of just creeps up on you. It doesn't usually onset in a cardiac way until they're in their sort of 40s, late 40s, up to mid 50s is where the most common age of onset is, but they can sort of front up in their sort of 60s and 70s, just being just a bit breathless. My heart looks a bit funny. And then you do an echo, and the echo that's on the sort of the side will show you it's like a person who's got a really thick heart. And you go, oh, hang on, didn't expect to find that. And every time you see a really thick heart, and it's a thick, stiff heart, so they're a heart failure with preserved ejection fraction, it just can't turn because it's just too chunky. So that's when you start to think about some of our infiltrative conditions, whether or not that's amyloid or sarcoid, or my personal favorite, which is Danon's. But Danon's is very rare. It's very interesting, but it's very rare, unless the person's from Turkey. If they're from Turkey, then Danon's is not uncommon. And there's Fabry's, which is also quite prevalent in the Southern European population. But the Fabry's, mostly in Australia, you've either found it in childhood or you found it through family screening, because they usually front up with renal failure rather than cardiac failure. But the Fabry's are also quite interesting because you've got a direct treatment that can reverse prognosis or reverse effect. So we do like a Fabry's. So if anyone's hiding a Fabry's, they're kind of fun. And they're usually nice people as well. But it's more depending on what's wrong with depending on what you see on the ultrasound, it helps you work out how far you have to screen. Sometimes you find a person who's an idiopathic first presentation in the family, who there's no family history, or I'm adopted, I don't know my relatives, and you just go, awesome. But we look at the next generation below them, so we look at their children if they have children. When we screen children, the rule of thumb is usually to think about if you've got a person who has required advanced therapy, whether that's a CRT, D, or things along those lines, or lots of drugs, screen the kids before they hit competitive sport. So we usually look at people when they're about 13, because childhood sport in primary school, they just follow each other. And then 13 is when they start to get serious and they start to do training and they start to increase their risk if they do have a dilated cardiomyopathy of sudden cardiac death. The guys from Westmead come down to the Canberra Hospital every 6 weeks. They do a very good service, and they're quite happy to be involved in family screening. And I would recommend using their service, because if there is a problem, you've hooked them directly into the people who'll be looking after them long term. And if they do need anything done, such as device therapy, or they need other fancy tests done, because they will need fancy tests done on them because they're young, then the Westmead guys can do that, because we don't have a particularly good cardiac MRI service in the ACT. And so we send out to Sydney, and doing a cardiac MRI on a 14-year-old is like torture. So you would prefer that to be done in a pediatric environment. I don't really, unless there's something floridly wrong with the child, I don't screen in childhood, and leave that to the peds people. But if it's mum's got this, mum's had this problem, I would recommend the kids get looked at by 13. We usually then would look at them again after they've finished school. So we would usually look at them about when they're about to take responsibility for their lives. So somewhere about 18 or 19. Most of them don't really give a rat's ass about 18 or 19. So then you usually catch them about 21. And then the other time we would have a look at them if they were completely fine. For the rest of the time is to look at them if they're female before they're considering pregnancy, or if they're male at about 30. And then if they're still normal, then you go, fantastic. But if they had a family member who onsetted with a DCM in their 40s, you kind of keep screening them unless you've gone through the genetic testing process, and we have quite good access to genomics and can do quite a lot of good genetic testing to see we found a gene in the affected person. We've then screened the family. You're not a carrier, therefore you just need one screening test. Looks fine. We'll go back a decade later. It's still fine. You're fine. But if they do have a genetic predisposition, but they haven't shown the phenotype, then we're a little bit more intense with those people. But when we have a wee look at some of the things we see on the scan, we can see some various changes from some of the parameters that we use a lot, which is basically looking at, has the GLS, which is basically how well it turns, has that changed? has the walls got chunky, and then as it goes on, you progressively get more failure because you get a heart that just can't rotate and it starts to dilate when it doesn't rotate. So this is a person who's got amyloid. So it's more kind of the case of when you have, this is a very nicely donated slide set from one of my mates in England. It's more kind of the case of as you take the wee pictures of it to have a look to see how things are moving, you see a heart that kind of looks a little bit fuzzy. And because it's a bit stiff, this person's actually developed a left atrial appendage thrombus, which you'll see on the last pictures, which is the toe. We also see this, I think, a particular pattern, which is with strain. And we talk about basically a cherry on top, because when you actually think about the heart turning, literally think of it like you're trying to empty to wring out a towel. You turn it forward, you let go, it springs back. We can measure how much it turns around. So when you see the thing that looks like a bullseye, you end up with the top moves, but the sides don't. So which is why the top is red and the sides are a different color. So it's each, you end up with basically, depending on where you're from in the world, most of the time it's basically ice cream with a cherry on top. But they do have a particularly sort of unusual experience of when you look to see how the heart itself moves, it just doesn't spring back properly. So if you see something that doesn't spring back properly, you think to yourself, well, hang on, this person's maybe got an inflammatory condition, and the more common, or the commonest one in the population that we see in Australia would be amyloid. So with amyloidosis, we actually then go on and we go back and bother the hematologist. So we have a look to see, is there something that we can do? And why we care is we actually have treatments now. So we actually, the way of looking at it is you do basically the easy things, which is to go and have a look for light chains. If you do have light chains, then it's hematology's problem. If they don't have light chains and you're still suspicious that they might have amyloid, you can do a DPD or a PY2P scan, which is a nuclear medicine scan. If that's normal, they don't have amyloid. If that's positive, then it's back to the hematologist because they need to think about a biopsy. We can go on and do some genetic screening. We do have a very nice medication that we have that's available that is called tafamidis if the person has got symptoms, and tafamidis has actually got some very good data of actually reversing amyloid cardiac disease, which is excellent. The other thing you need to remember is if you've got somebody with amyloid, and the same applies for hypertrophic cardiomyopathies, the minute they go into atrial fibrillation, it does not matter what their CHA2DS2-VASc score is, they need to be anticoagulated because their stroke risk is higher than just a normal person who's gone into atrial fibrillation. So the other group that we also forget about a lot is the right-sided failure people. There's a lot of things that are involved in right-sided failure. Most of the time, it's more kind of the case of it just doesn't work. They've rolled up because either they're just breathless. Quite a lot of the time you talk to them and they're like, I just feel really bloated. My LFTs have been funny. I think I might have fatty liver disease. I've had a liver biopsy. I've had my scopes. Maybe I just have irritable bowel. And then you look at them for a bit and you're like, hang on, but your JBP is past your ear. We need to sort of remember that these people are sort of, their right ventricle is called forgotten ventricle in cardiology because it's something you can't really stent open. So consequently, we've sort of been ignoring it. But if you've got good and proper right-sided failure, you get quite a lot of problems with basically the lungs. The easiest way of remembering it is the left side. When the left side falls apart, it goes to the lungs. When the right side falls apart, it takes out the rest of the body. You end up with basically your hepatic impairment, malabsorption, your drugs go off, they end up in more failure. They also end up with quite a lot of brain changes, and they seem to be quite sensitive to reduced cardiac output, and so they are the ones that get confused more than the ones with left heart failure. If your left heart failure is bad enough to cause you to right heart failure, you're running into end organ damage. But the right heart failures as an initial presentation, we do see dilating right hearts, person who's got sleep. The typical one is a person who's had maybe a right-sided infarct a while ago. They've been coping okay. Then they decompensated because either they threw a blood clot or they sort of got older. The right ventricle started to dilate more. Then they've started to develop pulmonary hypertension, and then you're in a slippery slope to problems. So if you look at the sort of data to see what would happen if you develop pulmonary hypertension, it's basically a very short road. If you've got thromboembolic disease, then we do have a few things that we can do. There is a lot of people in Sydney looking at pulling out the little clots if you've got a thing called chronic thromboembolic pulmonary hypertension. which is effectively taking out the lungs, pulling out all the little clots out of them, and then basically hoping that things work a bit better. But as you would imagine, that's you're in the world of pain when you're starting to think about doing that. We do see a lot of people with right heart failure, which are related to the lung doctors. So we like to sort of say, oh no, it's definitely your COPD that's causing problems, but we also need to take a bit of responsibility. This is where your SGLT2s are quite useful. So when we look at some of the pulmonary hypertension literature, we are using them to actually drop pulmonary pressures. And so if the patient doesn't qualify for some of our fancy drugs or Viagra and its friends or the various other medications we have for PH, because we have some very good medications now available for pulmonary hypertension, then you can use diuretics to offload them, but the actual decongesting of the lung-heart interface does seem to work very nicely with the SGLT2s. And in this circumstance, empagliflozin seems to be better tolerated than dapagliflozin, and I don't know why. And it might be my N=1 clinical trial, but it seems to be one seems to be preferentially working a little bit better, and it just seems to work that way. So I have a bit of a preference there. But if you haven't done anything to the right heart and the right heart starts to run into problems, you then start to end up with modeling. The RV dilates, the RA dilates, then you get TR, and then it just accelerates. Whether we do have the options available for a thing called a tri-clip. So a tri-clip is like a mitral clip, which is if you just think of it like you're not safety pinning, but you're getting like a little paper clip and you're collecting the side of the valve together, and you're sort of closing it from leaking as much. So then you can basically reduce the amount of volume going backwards. So the heart's supposed to be a one-way system rather than a two-way system. If we get it to all behave itself and go appropriately forward, we can then get the pulmonary outflow to work a little bit better, take a little bit of load off the right ventricle, because the right ventricle is not a thick structure. It doesn't like working very hard. So then you can sort of give it some time for some of the drugs to work. So we are starting to use tri-clips a little bit more. It's not, the only place that's actually doing them on the public system is Melbourne at the Heart Hospital. The tri-clips aren't being used in Sydney. They were being used in Sydney for a little bit of time in St Vincent's, but they've run out of money because they were doing it on charity money, and they were doing it on clinical trial. But if the patient is a private patient, RPA are happy to help. Everywhere's happy to help if they're a private patient, but there is the people who've got the most experience with doing tri-clips in our immediate area probably would be the RPA group, followed by the Minis group, because they have been doing it a lot. But it is quite useful if you've got a person who's got roaringly bad TR, roaringly bad right heart failure. You've tried everything. You've got them as diuretic as far as you can possibly go before you're thinking to yourself if they're about to be signed up for dialysis, and they've still got roaringly bad tricuspid regurgitation. It's quite useful to have a bit of a think about, would this be a particularly good option? We have had some other device therapies that we've thought about using in to try and improve the tricuspid valve, but it goes under the theory of if there's more than 10 different options, none of them work. So it's more kind of the case of they're trying to develop one that will actually be functionally stable, but we have yet to get there. But you need to keep thinking about, you can't keep pulling diuretics and more diuretics into these people. So it's more kind of the case of you have to start thinking a little bit outside the box. So that's when we start to think about some of the other things, which is basically fixing their TR with a mechanical device. If they have a lead that's sitting there, quite a common cause for problems with the right heart is basically the pacing doctors have been there first. They're very good at putting in the leads, but they don't really care where the leads lie. When I was in Cambridge, we basically had a study that was looking at how much TR do the EP doctors cause, and then we would get to the point if the grade of your tricuspid regurgitation had gone from mild to moderate. If anything had gone up a degree, then you had to get the EP doctors the day after to reposition the lead so that you actually could keep the patient with the same degree of leak in the valve, because they were seeing quite a lot of device-associated tricuspid regurgitation. It's also quite common if people have got multiple leads in, but there's not that many people wandering around in the ACT that have multiple leads sitting in their right ventricle, because the lead extractors that we have in New South Wales are very good, so they usually take things out. If you've got a person with no other cause that you can find and they've just got impaired right ventricle, you need to start thinking about things like ARVD, because that's not uncommon, which is arrhythmogenic right ventricular dysplasia, which has actually changed its name again. So it's now arrhythmogenic ventricular dysplasia, because you can see it in both the left and the right heart. It used to be primarily thought to be a right heart disease, but now it's a both ventricle disease. It's one of the indications that you can get a cardiac MRI for. So it's amazing on how many people are diagnosed with ARVD until they've had their MRI, which is normal. But it's more kind of the case of it's something to think about if it's a younger person. There's just something a bit funny about this ventricle and it just doesn't move as well as it should. That's when you start thinking about ARVD, and then they usually go on to develop horrible rhythm problems. If you've got a person who has got impaired function for the right and the left heart and they're out of rhythm, try and get them back to rhythm if you can. Try and put them back on the standard therapy if they've got reduced ejection fraction or preserved ejection fraction. If they've got problems with their left heart, fix that because it puts pressure on the right heart. And then also remember everyone's favorite answer of if you can't get an answer and the right heart's failing, you've done all you can from a heart perspective. Don't forget to blame the lung doctors. So then you go off and have a sort of, definitely it's a problem with pre-capillary pulmonary hypertension. So that's under the referral physicians, not cardiology. Now, does anyone have any questions?
Thank you very much, Sharon. That was extremely comprehensive, and there's lots of things that we can take away from that. The four favourite medical classes for heart failure, ivabradine, what to do with asthma. Don't forget iron. Don't forget the lungs. That's really very useful for
Blame the
GPs.
lungs. That's a good answer. Blame respiratory.
Yeah. I just had one more question, and I've always wondered, how can acute stress cause a cardiomyopathy? So how can like an emotional reaction cause a cardiomyopathy?
So that's where you get to Takasubos,
Yeah.
which I do like Takasubos. The coolest thing about Takasubos is Takasubos was diagnosed by vets 15 years before humans found it. So it's why large apes used to go into captivity and die. So the actual mechanism behind it seems to be related to a sort of a noradrenaline release. There seems to be an overlay with how it interacts with progesterone because it's got a female predominance of like 9-to-1 females versus males. But we don't know the mechanism. We think it's due to basically a stunning effect, which is why, because it's transient and usually self-resolves in about like 5 days usually. And it's because it's a reversible. It's diagnosed as exclusion, but it's reversible. You can't be stressed and get a dilated cardiomyopathy. You can be stressed, get a Takasubos, and then it reverses. And if it's a stressed and I've got a dilated cardiomyopathy, it's usually you've got a tachycardia-induced cardiomyopathic process rather than which is you've been stressed, so that you've been tachycardic because you've got a big cortisol surge. But that's relatively rare. The stressed ones of my life is disastrous and somebody's just died and now I can't breathe. Acute things are usually a Takasubos until proven otherwise.
Right.
And they're usually quite interesting because you've got a recurrence rate of about 15% with Takasubos. So once they get it, they're not completely in the clear. But the typical story is funerals, car accidents, World Cup soccer, because it's a really cool paper. It's a really interesting paper that was in one of the Christmas BMJs, which was basically of the rates of Takasubos when Germany was playing England. And it was because England lost. So there was a high rate of Takasubos at the time. It was quite funny.
That's
So
incredible. Yep.
no, it's fabulous. So people, when I was in the UK, they used to actually sort of go, I'm not working that night. And I'm like, why ain't working that night? You're going to go watch the football. And they're like, no, I don't want to have to deal with Takasubos. And I'm like, what? And then like, you're rostered. And I'm like, you joking me? And they're like, no. And I'm like, oh, okay, fine then. We don't see the same effect in Australia, but I think we're not as passionate as the European football followers. But it is an interesting thing to see as a phenomenon.
Yeah, yep. So we've got a few more questions. So just one of them. So sorry to confirm, inherited hypertrophic cardiomyopathy, should I screen the grandchildren?
So if it's an inherited cardiomyopathy, if it's like a decent, so it depends on which type of cardiomyopathy it was. So if it's if it's a hypertrophic cardiomyopathy, yes. If it's a dilated cardiomyopathy, if the first generation below them is fine, I wouldn't bother screening the grandkids. If it's one of the rhythm problem ones, I would screen the grandkids just so you get an idea. But it's usually more if the generation below looks fine. So if the proband or the person who's in the middle, so the person you have who has symptoms and you're worried about them, if it's one that you think that you go look at their children, if their children are okay, you don't need to go to the grandkids. If their children aren't okay, then you need to go to the grandkids because you've now moved the proband to the child of your original patient. But if it's an older person for a dilated cardiomyopathy, they're so common in old people that I wouldn't bother screening. If somebody rolled up at 60, I wouldn't be screening the 80-year-olds, but I would be screening if they had kids that were in their sort of 30s or 40s. But I don't go and screen so if somebody turns up at 60, I would screen their sort of 35-year-old child, but I'm not going to go and screen their 10-year-old grandson. I'm going to wait for the 35-year-old to develop symptoms before I go or changes before I go and look at the kid,
And
unless it's open.
how often do you see a dilated cardiomyopathy in people with connective tissue conditions, so that, the EDS type conditions?
Everyone's favorite brand EDS. So because I'm sure you guys see EDS as much as I see EDS or query EDS, query pods. Basically it's a case of within the EDS world, we have the one that we get worried about is vascular EDS, which is one of the more uncommon ones. There you can find on an echo pretty fast. So they end up with basically a mitral valve prolapse or an aortic valve prolapse. We usually follow the EDS patients not from a cardiomyopathy like a DCM type thing. We see them for aortic issues. So we see them a lot for people who've got an ascending aortic aneurysm because there's an overlap with them having dissections, which I find interesting. So I see quite a lot of EDS people primarily to look at their aortas. The DCM with EDS type things, it's not that common. We would see more DCMs with that go with random sort of like joint things like psoriatic arthritis and things along those lines than we would with connective tissue disasters. The connective tissue things is, think of it more of your like little suspension doesn't work. Your heart basically has got a lot of things to brace it, but your aorta doesn't. So your aorta will dilate. So they're more aortopathies rather than sort of a cardiomyopathy. So they're similar but slightly different.
Right. Another question, and tachycardia with ADHD medications, what's the consensus risk?
Oh God. So it's not that high because I think in like the ADHDs, they're always a bit fun to play with, and they will remind me that I probably need to get my ADHD looked at. That we usually don't give them the stimulating version, so we don't usually let them have the dexamphetamines. If they have something that looks like it potentially why the psychs get very upset about it is well, in all fairness, I can't do a mini mental state assessment anymore. They don't really know what an accessory pathway looks like on an ECG. So if they've given a accessory pathway patient dexamphetamine, you will then you potentially have a risk of sending the patient 1-to-1. And the rate of that happening is not uncommon, but it's unusual, but not uncommon. So I would say that your risk is still relatively low, but if it's something that they've got a history of palpitations, they've got syncope or things along those lines, then I'd be like, maybe less of the sort of stimulating version, but it's more about have a look and see if they've got long-term monitoring, see if their base ECG is normal. And then we usually let the psychs do what the psychs need to do. Quite a lot of the patients who've got ADHD or who are on the autistic spectrum are going to be tachycardic when they come in and see you because they're not a fan of the idea. And that's where long-term monitoring becomes very handy. We have got some very good long-term monitors that are available because you can get halters at a drop of a hat. Everybody does halters. And the other thing that we are doing a lot of, and I'm sure you're seeing a lot coming back in your practice, is heart bugs. Heart bugs are a very nice test because the company bulk bills the patient. And they can have a monitor on for about a month. And so they usually pay for having a fitting fee of wherever they're getting it put on, and then they wander around, and then you get a good long-term information about what's actually happening because the heart rate, I've got a very, really nice one of a person whose heart rate was in the office was 130. The minute they took should have put a GPS on her. The minute she got to the car park, her heart rate went to 70. And then she was happy the whole time. And then in the walk going back to drop off the monitor, her heart rate went to 130 and stayed there. So every time we were like, maybe we need to think about beta blocking you. Like, but you seem fine. But she was just so freaked out when she came anywhere near doctors that her heart rate just stuck at 130 and wouldn't move. And it's it's a sinus attack rather than anything else, and you just look at it and you go, there's something sus on this. So if it seems a bit strange, monitoring when they're away from you, it's kind of like BP monitoring. You can get a good idea of what they're doing when they're not in front of you, because there are a lot of people that they sort of will reassure you they're totally fine, but they're not, and their heart rate is sort of consistently high. But you want to also see, the one thing that gets very concerning is if you have a look with a Holter, is, are they tachycardic when they're asleep? If you're tachycardic when you're asleep, either you've got, the three things you think about is you've got really bad heart failure because you're trying to cope when you're lying down. You're either in a rhythm that needs to go away, so you're sitting in either an atrial tachycardia that you're just stuck at one speed and you can't drop, and they end up with a cardiomyopathic process. And those or the other ones is they've either got a rheumatological problem, but they're usually running at about 110, not 130, or they have they're using some very impressive drugs, and they will consistently stay fast. But if your nighttime running, if you have no variation between your nighttime and your daytime heart rate, you've got problems. Is the best way of describing it.
Yep.
But it's when you use Holter monitors is very handy then.
We've got another question about, I guess, heart rates and things like, do you look at smartwatch heart rate monitoring much?
I quite like it. So, and if you've seen me, I wander around with my Apple Watch on all the time. They're very good for giving you a trend. The ECGs off them are junk most of the time. The heart rate variability score on your Garmin watch, I would happily bomb that out of Garmin's headquarters because it's a mathematical construct based on nothing. But looking at what their heart rate does is kind of handy. So I quite like them. Moya he doesn't mind them. He likes the scan watch because the scan watch seems to be more accurate for basically finding rhythms. They're not very good at finding is this AF or not. They're useless for that. Their bradycardic alarm thing is not great either, because it's very sensitive. So we would say that if you're pausing for more than 2 seconds, then we'd get a bit worried. But theirs is set for like you've dropped once, you've dropped a beat, boom, you're getting an alarm. And that's the Apple one. Or if it's one of the Google ones, you have to be bradycardic for like half an hour before it will send you an alarm, which is a little bit of the other extreme. So they're useful for trend. I wouldn't say that they're useful for ECG, but I do like them, especially if you've got a person who says, oh, I'm tachycardic all the time. And you're like, okay, show me on your watch. And then you flick through it and you're like, your average heart rate's 70. I think it's fine. But it's quite handy for people who sort of feel like they're running fast. But it's also kind of useful to get an idea of if you can up-titrate drugs. So it's kind of useful for, I like using it in older people if they have one, to get them to wear it primarily, firstly, because it's got a false alarm in it, and secondly, because it gives us an idea of what their heart rate trend's doing, because you can pull off your average heart rate pretty quickly.
Right. Thank you so much, Sharon. Just to let everyone know that we will be putting the recording of this webinar on our Capital Health Network YouTube page in probably about a month after it's been edited. So yeah, you can revisit all the things that Sharon's talked about tonight, which has been really fantastic and so useful for us GPs. So thank you so much, Sharon, for all your hard work and your wonderful presentation. Just a reminder for attendees to fill in their evaluation surveys, and also to self-record 1.5 hours of educational activities. Our next webinar will be in 2 weeks on arrhythmias with Dr. Mohammed Paymat. And thank you so much, Sharon. That was really great. Thanks. Good night.
No problems. Good night, everybody.